About 10 weeks ago now, 1st of April, in fact, a surgeon at the Royal Marsden, breast cancer surgeon, Peter Barry, contacted me with a problem which has arisen, real challenge for the clinic as a result of the COVID pandemic. And this related to the actual management of newly diagnosed estrogen receptor positive, HER2 negative breast cancer patients. And these make up around about 70% of the overall breast cancer population. And the issue was that these patients were being deferred from surgery, which they would normally get within 2 or 3 weeks, to neoadjuvant endocrine therapy. The reasons being that the management of these patients was deemed unsafe. The patients coming into the hospital could bring safety issues with them, could bring infections, but also, in particular, the availability of resources for their surgery was actually quite limited. Peter knew that we had recently been doing, and indeed have been involved in studies, where we've been taking biopsies from patients about 2 weeks after they had started neoadjuvant endocrine therapy or just short-term pre-surgical endocrine therapy, and measured Ki67 in this, a proliferation marker. And the level of Ki67 was correlated in these studies to long-term outcome. So Peter felt that maybe there was a way in which we might be able to identify those patients that could be safely managed with the neoadjuvant endocrine therapy for several months, but also, at least equally important, to identify those that were not likely to be managed well in this and therefore needed to be moved as soon as they could to either surgery. So I set about looking at data we had in hand here from, in fact, 3 clinical studies in which these measurements have been made. A trial called Poetic, which is a UK trial of around about 4,500 patients, shortly to be published in Lancet Oncology. Palette, which was a study of letrozole plus or minus palbociclib, and that was published at the start of this year, the Palette trial in the Journal of Clinical Oncology. And then another study of anastrozole plus or minus gefitinib, also published in Journal of Clinical Oncology, but several years ago. And from this, we worked out, in fact, that there was a way in which we might be able to give some information without actually taking this core cut biopsy 2 weeks into treatment. That would obviously be an advantage because the resources for radiology were also limited during the COVID crisis. So by looking at this data, we could see that there was about 5% of patients whose estrogen receptor and or progesterone receptor levels were very low, despite them being estrogen receptor positive. And these patients really needed to go to surgery as soon as they possibly could. And then the other end of the scale, there was about 60% of patients who clearly could be managed well. This is the patients with a very high ER levels, high PGR levels. But in the middle, we were left with about 35% of patients. Therefore, normally these might be patients who would again go to actual core cut biopsy and the Ki67 analysis measured. But actually, we've then looked at the pre-treatment Ki67 levels, and one could see that there, by looking at these, we could reduce the number yet further that would need the core cut down to about 20%. Now, this is all very well. This is our own data, and we trained this, if you like, algorithm on that basis. But as anybody who's been involved in biomarker work knows, that it's really critical that one validates the algorithm or process on other sets of data, independent sets of data. And it was great, therefore, to be able to initiate collaborators, people I know well, Nadia Harbeck and her group in Germany, and Matthew Ellis and his group in Houston. And they had not exactly the same sets of samples, but they did have sets of data in which this 2 week, or in their case 3 to 4 week biopsies, where Ki67 had been measured. And they were also able to look at estrogen receptor and progesterone receptor levels. And essentially we came up with exactly the same findings. So eventually we end up with an algorithm in which the clinicians just look at data, almost all of them already have the estrogen receptor and the progesterone receptor levels at the start of treatment, diagnosis. And that immediately can give them information on about 2/3 of the patients. In some countries, Germany, not so much the UK, Ki-67 is also measured pre-treatment. So if that Ki-67 is available, the clinician can use that and then reduce further the number that we might take to biopsy. And those patients, or those countries rather, where the Ki-67 is not available, they could then go and do that pre-treatment Ki-67 level, or they would have to just do the 2-week core cut. What it means is that in about 85% of patients, we can now confidently say those patients can safely be managed with neoadjuvant endocrine therapy. We say for up to about 6 months. But also the 15% of patients we will wish to put through to surgery as soon as possible, according to resources, according to COVID safety. And really, this is something which has been met with enthusiasm with surgeons, certainly in London, the London hub. We're implementing it in the Marsden, obviously, and it seems likely this is going to have impact in many countries. It really does matter a great deal as to exactly the situation related to COVID in the actual population, the local population. But even in places where they're now able to do surgery, many of these centres have actually accumulated large numbers of patients in the meantime, and therefore application of the algorithm looks as if it will be valuable in managing this as they begin to cut into that backlog. So one of the terrific things about this study was the speed with which we were able to do it, from really the April the 1st call from Peter Barry to the publication just 9 weeks later in the NPJ Breast Cancer. This level of collaboration in the setting of this emerging was really totally unprecedented in my experience, and I've had quite a few years of experience of collaboration with different groups around the world, with groups being prepared to make available unpublished data in a very rapid fashion. Many telephone conferences, Zoom calls, etc., to bring these together. And only in that way could we have delivered this as quickly as we did.